speaker for today is Jennifer Mann, who's going to be talking to us about cough and interstitial lung disease. But I'm going to hand over to Nicole Go, who's going to more formally introduce Jennifer and tell us a little bit about what her group's been doing. So I'll leave it to Nicole to carry forward.
Thank you, Paul. Good morning, everybody.
I'm sitting on the
Sorry.
Was this my introductory song? Thanks, Paul.
I'm trying to remember.
Okay. So Jennifer Mann is a respiratory and sleep physician. She did she did advanced training at Frankston Hospitals and Austin Hospitals. And then she went on to do a one-year fellowship at the Royal Brompton Hospital in the Interstitial Lung Disease unit. And she's really returned, really with an interest in the symptomatic management of chronic lung disease, in particular, patients with pulmonary fibrosis. So she's going to talk to us today about that. She's 2 years into a PhD. She's doing a PhD with myself, Yet Cole, Anne Holland, and Ian Glaspole. And so she's 2 years into it, and she's going to tell us what she's done and what she hopes to achieve in the coming years. Go away, Jen.
Thanks, Nicole, and thanks everyone for coming. So the title of my talk today is Cough Measurement in Interstitial Lung Disease, and beginning with the patient experience in mind. So the patient is our starting point. And I'll just, hopefully that's going to move on. So just going to make sure I can move through the slides in this setting. Yeah, perfect. So the rationale for my research work, which forms the basis of my PhD.
Sorry, Jen, I don't know if I cannot see your slides on the screen.
Yeah, we can't see your slides, Jen.
Need to share.
I'll just share again.
Oh, yeah.
Yeah, okay.
Whatever you did last time seemed to work. Here we go. Here we go. All right.
All right, is that working for us?
That's better. Good job.
Perfect.
Okay, so the rationale for the research, as many of you will know from your clinical and research work, is that patients with interstitial lung disease have debilitating symptoms and few treatment options. And this is despite our recent advances in looking at pathophysiology and disease modifying treatments. So we mustn't lose our focus on improving quality of life and reducing symptom burden in this patient group. The ability to measure cough will improve clinical assessment and clinical trial outcomes, and it's increasingly recognised that patient-reported outcome measures are an important way to measure these outcomes in clinical trials. There's no current patient-reported outcome measure for cough that's been prospectively developed and validated with interstitial lung disease patients. And an ILD-specific measurement instrument is crucial to accurately and reliably measure cough and response to treatment in these patients. And a future measure should include aspects of cough that are relevant to people with ILD, as the generic or more existing measures may not capture ILD-specific impacts, particularly related to disease progression and treatments. So the overall research aim for my PhD is to develop an ILD-specific cough assessment instrument for use in this patient population. And when thinking about the research outline, it comprises of a number of studies. Study 1 is to describe the experience and burden of chronic cough in patients with ILD. Study 2 is to identify all the patient reported outcome measures for cough that have been applied to the ILD population, and to summarise their psychometric properties, the method of administration, and the usability of these PROMs. And study 3 is to define the domains and generate items for a cough instrument in patients with interstitial lung disease, and to gain expert and patient participant opinion to ensure the content validity. Study 4 will evaluate the measurement properties of the cough instrument. So I'd like to present for you today some of the data that we've gained from the qualitative study. And this was a study exploring the experiences of patients with interstitial lung disease. And we did this using cross-sectional, semi-structured telephone interviews with purposeful sampling of adults with a diagnosis of any ILD of any type and severity, with our exclusion criteria including those patients who might have a concomitant respiratory disease such as lung cancer or bronchiectasis, COPD or asthma. And we also excluded those patients who had an acute exacerbation. So in this case, they had to demonstrate stability over a 12-week period before they could be considered. Similarly, for acute infection, participants had to demonstrate 4 weeks of stability before they could be considered. We recruited until thematic saturation and then performed thematic analysis. So this slide gives you an overview of the interview process. We collected data for 16 participants. We recorded telephone interviews with audio recording, and this was predominantly due to the COVID pandemic, but also due to the older patient population in this group. Audio recordings were transcribed verbatim, and data analysis was performed by 2 researchers. So transcripts were read line by line and fragmented in just 2 descriptive codes. And then the codes were organised to form themes and sub-themes. The final themes were agreed through discussion. And at this point, I'd probably like to thank Yet, who I think might be at ATS, but has contributed significantly as the second researcher to perform the analysis. You can see here the starting interview topic guide with some of the questions that we asked, although it was very semi-structured. So this did change over time, particularly as new themes arose. So this table here has the demographic data and the selected clinical characteristics of the participants. And you'll notice split into equal groups of male and female. We had 11 participants with idiopathic pulmonary fibrosis, 2 with connective tissue disease associated ILD, and 3 with chronic hypersensitivity pneumonitis. The forced vital capacity ranged in terms of severity from 53 to 107% predicted. And similarly, gas transfer, there was a wide range of patients. Common comorbid conditions in our patients included obstructive sleep apnea and reflux, which were relevant to the chronic cough population. And the majority of patients were on an antifibrotic at the time of the interview. So during the thematic analysis, 4 major themes and 2 minor themes emerged. So the major themes included cough characteristics, cough impacts, cough triggers, and the educational needs and self-management for patients. And then the minor themes were cough interpretation and the impacts of the COVID pandemic. And I think undertaking this study last year, that's really something that was inescapable. So I'll go through some of the qualitative data here. And I've got on each of the slides here, I've got some illustrative quotes from the participants. So the first major theme was cough characteristics. And there really was a diversity in the description of the cough characteristics. Frequently, the cough was described as a daily cough, however, with day-to-day variability. And a surprising number of participants described a productive cough, with sputum clearance occupying their time and energy and impacting negatively on their quality of life. As people with an alternative respiratory disease or obstruction on lung function were excluded from the study, it's possible that this represents inter-individual variation or the impact of comorbidities on sputum production, or perhaps something that we don't know about cough in this patient population. So an example here from one of the participants, but my cough is not really a dry cough. I have lots of mucus and sputum. And every time I cough up the sputum, and then I have the mucus in my nose as well as at the same time. We looked at cough impacts, and this was perhaps the largest theme that emerged. And the impacts of cough included both physical and social impacts. So participants associated their cough with a number of physical symptoms, and this included wheeze, sneezing, weight loss, fatigue, and dry retching. Fatigue or exhaustion, as was one of the other words that they used, related to coughing bouts and was mentioned frequently. And patients used strategies such as pacing and limiting their physical activity to deal with this. Breathlessness and cough often occurred together, and our patients were very careful to distinguish the impacts of each of these during the interviews. Cough often followed breathlessness, although the opposite was true for a smaller group of patients. And the fatigue that they described was clearly linked to coughing bouts. According to patients, chronic cough in ILD significantly impacts their public engagement and social participation, physical activity levels, and their daily routine. Most of our older patients with more severe ILD had to rearrange their daily activities to accommodate cough. The morning routine for many involved clearing sputum and using breathing techniques to settle cough after showering and dressing. And for some, this routine could take up to an hour. They described withdrawing from previous hobbies that involved exposure to cold weather or public speaking, with a preference for quiet, seated activities. In the younger group of patients that we interviewed, and those who worked full time, it was interesting that a lot of them had the attitude that I've just got to get on with it, and didn't feel that cough limited their ability to work. So triggers for cough were diverse, and these included aerosol exposure, lower respiratory tract infection, temperature and humidity changes, poor air quality, windy weather, eating and certain foods, smells and fragrances, talking and laughing, deep breathing, and physical activity. So some identified stress as an exacerbating factor. And some of the triggers were also associated with throat symptoms, such as hoarse voice, tickly throat, or a sensation of needing to clear the throat and globus. These were fairly common, such that an element of cough sensitivity might actually be raised as a possibility in these patients. All patients that we interviewed had a clear awareness of the role of their comorbidities in contributing or worse, exacerbating their cough. And this included their obstructive sleep apnea, for one participant, cardiac arrhythmia, sinus congestion, and allergic rhinosinusitis. All patients experienced an eagerness for more knowledge on the cause and triggers for cough, as well as strategies to control cough. They recognised that cough is experienced differently by each individual, and that a personalised treatment approach was required. Very few participants had accessed any information on managing cough from online or other sources, including their general practitioner and specialists. Patients commonly reported that the focus of their consultation with their physician was centred around diagnosis, investigations, and disease-targeting treatments, and the management of cough was rarely discussed, although they did recognise that this was what they would like. They actually saw the role of cough management as should be conducted by the clinical nurse or the general practitioner or the pharmacist. And so they were eager to pursue this, but outside their physician reviews. Regarding online information, our patients generally reported that they avoided forums as they found this information to be depressing and overly negative, and some mentioned that they preferred peer-reviewed information delivered by someone who was a specialist or expert in the area. Self-management strategies that our patients adopted were varied and included the use of mucolytics for sputum clearance, CPAP for nocturnal cough, the use of throat lozenges and warm drinks, pacing, breath control and relaxation exercises, movement and supplemental oxygen to relieve cough. The majority described pulmonary rehabilitation as being very helpful for cough. But overall, many had tried multiple treatments with limited effect. There was the perception that available treatments were impractical or caused unwanted side effects. For example, although patients frequently described opiate-based Linctus as effective, its use was limited by restrictions on driving, sedation, and the small amounts supplied on prescription, resulting in rationing for emergencies or planned activities. One quote here is that my recollection is that everything works the first time you try it, but then the disease overcomes the medication because it gets used to it. So moving on to the minor themes now, and cough interpretation was a minor but interesting theme to look at. So patients saw cough as a reminder of their disease. When they coughed, they reported that it reminded them that they had a significant illness. However, overall, they generally accepted it as an inevitable symptom of interstitial lung disease. Some associated cough with lung damage and reduced lung capacity on their respiratory tests, and many reported that when they had coughing fits, they were interested to know what their lung function would be showing on that occasion. Only one participant associated cough with significant hypoxia. Here's an illustrated quote on at the bottom here. So I do wish it would go away, but I know that it's not going to happen. I've accepted that. As I said before, the impacts of the COVID pandemic were really inescapable over the course of last year. But however, it was quite interesting to gauge the participants' views on this. Many reported that face masks were a trigger for their coughing fits. So that was a physical impact of the COVID pandemic. But interestingly, some reported that the social isolation actually assisted with their cough management. They'd stay in their own home with a constant temperature in the home, doing quiet activities, and weren't forced to go out and socialise. They did, however, notice the stigma of coughing when they did go out, and this was associated with anxiety and self-consciousness. But I find when I put a mask on, the minute I walk into a shop, I start to cough, which makes the whole store jump to the side, thinking it's COVID. And I think I keep explaining to others, I've got a lung problem. It's not COVID, I've got a cough. So this ends the themes that we looked at elicited from the data. And the hope is that these will contribute now to the development of a conceptual framework of chronic cough in interstitial lung disease, and contribute to the provisional domains for a symptom and disease-specific measure. And I think as I go through this talk, it's important to think of the role of the development of the conceptual framework in developing a patient-reported outcome measure. In the past, when measures were initially developed, it might be a group of experts sitting in a room coming up with all the items themselves and then testing the measurement properties. But more and more now, we're generating the items from patients themselves. And I think this process is important. So just to review, the conceptual framework explicitly defines the concepts measured by the instrument. And you can put this in a diagram, and it presents a description of the relationships between the items, domains, or sub-concepts and concepts measured, and the scores produced by a patient-reported outcome. So in generally now, it's accepted that you generate items through a combination of literature reviews, expert opinion, and patient interviews, focus groups, and qualitative cognitive interviewing, and that eventually with the development of the tool, the exact words from the patients are used to represent the concepts measured by the domains or the total scores derived using patient input. So with that in mind then, we've got first of all qualitative data, and then we also conducted a systematic review of patient-reported outcome measures for cough and interstitial lung disease. And I'm not going to go through all the results of this today. It was presented at TSANS and it's recorded. But for those of you who weren't there, just to give you an overview of what we looked at. So we looked at which patient-reported outcome measures for cough have been used in adults with interstitial lung disease. And then we examined their psychometric, or the evidence for their psychometric properties, such as content validity, construct validity, structural validity, internal consistency, and reliability. And then we looked at how the patient-reported outcome measure was administered and the usability or time required for completion. And this is just a summary of the different patient-reported outcome measures that arose from the systematic review. And you can see there's some old favourites like the Leicester Cough Questionnaire and the Visual Analog Scale, and then probably some other cough-specific measures that people might have used in their practice or clinical research for patients with other lung conditions, such as the Cough Quality of Life Questionnaire or the Cough and Sputum Assessment Questionnaire. There were also a number of quality of life questionnaires that had cough as a domain rather than being a cough-specific questionnaire that we looked at. And whilst we found that there were no patient-reported outcome measures for cough in people with interstitial lung disease that supported each of the measurement properties that we looked at, and actually quite limited information in diseases other than idiopathic pulmonary fibrosis, there was the sense that progress is being made. And we did have evidence for content validity for the ATAC IPF at the top here, the Cough and Sputum Assessment Questionnaire, the ERS for COPD, and the Living with Idiopathic Pulmonary Fibrosis Questionnaire. And we saw strong evidence for internal consistency for 11 of the patient-reported outcome measures. Interestingly, there's been a lot of the studies were since 2010, and that suggests the recognition of the need to validate existing PROMs and also to develop new disease-specific PROMs. And this exercise was particularly useful, I think, in the practice of developing a patient-reported outcome measure to really go through in some detail the development process from others and looking at also the psychometric properties and the structure of the questionnaire. So now we come up to study 3, which is to define the domains and generate items for a cough instrument in patients with interstitial lung disease, and to gain expert and patient participant opinion to ensure the content validity. And once again, thinking about this and how it relates to our conceptual framework of the patient-reported outcome measure. This is just a reminder of the structure of the conceptual framework and the measure, and thinking about our general concept of chronic cough and interstitial lung disease, and then breaking this down into domains that measure a particular dimension of the concept. And then so for instance, some possible domains that we might use include cough severity or cough impacts. And the domains can be further divided into subdomains. And one example of a subdomain of cough severity is cough frequency. And then the subdomains can be further divided into items. And these are the questions or the statements that are used in our patient-reported outcome measure to measure the various aspects of cough. So thinking about that structure as we go into a process of developing the items. So what's next? So we're about to do another project that consists of 2 parts involving expert opinion and patient focus groups. And the aims of this are to achieve consensus among health professionals and people with interstitial lung disease on the domains and items for inclusion in a working version of the disease-specific PROM for cough. So as I said, this will be 2 parts. The first part is a Delphi survey of international experts and physicians who attend specialist ILD clinics or ILD multidisciplinary meetings, specialist cough clinics or cough multidisciplinary meetings, and clinical nurse specialists, physiotherapists and speech therapists with a special interest in ILD or cough, and then health professionals that have contributed to the fields of ILD by either research, publications or clinical guideline working groups. So perhaps this will be a sneaky advertisement to some of you in the room here if you would be keen to be involved. Part B will involve patient focus groups and largely using a similar inclusion criteria for our initial qualitative interviews with people with a diagnosis of any type and severity of interstitial lung disease who've had the presence of chronic cough lasting over 8 weeks. We will try to capture a few more participants in this group who are of working age to make sure that we capture all those aspects of cough that might be relevant to our patients in the final tool. So both parts will be intertwined in this method for this project, and we're going to split it into 2 rounds. So first of all, in round 1, we'll have the Delphi survey of expert health professionals, and we'll ask our experts to judge the importance of the proposed domains, subdomains and items that we've derived from an initial qualitative and work and systematic review, and to judge them based on a 9-point Likert scale from 1, which is not important, to 9, which is critical. And then the results of the survey will be analysed and we'll define consensus beforehand. For instance, if 70% of the participants score the item as critical and under 15 score the item as not important, the item will be prioritised. Results of the Delphi round will be presented to the same focus group, to a focus group of people with ILD for their perspectives. And they'll be asked for their thoughts on the items, both those with and without consensus, and they'll identify any additional items that should be included. And we'll feed that back into the second round of the Delphi survey, noting that overall, at the end of this process, really the patient participants will predominate over our expert health professionals, so that we'll probably include more items than we would exclude, pending a further process of item reduction later down the track. And here's an example of the sort of question that we might ask in the survey. So in this example, looking at within the domain of cough impacts, how important are each of the following subdomains? And we talk about subdomains such as physical function, emotional function, impacts on mental function, and impacts on occupational hobbies and activities. And then once we're finished this process, our work isn't done, and we'll be thinking now about how the individual items are associated with each other and how are the items associated with each of the domains and the general concept. And then we'll go on to confirm this by measurement of property testing. So some work to do yet. So they're my formal slides there that I'll finish, and I've got my acknowledgements there and my contact details if anyone would like further information. But you may get an email in your inbox in the next month or 2. Thank you.
Thank you, Jen. So do you want to Thank you, Jen. Paul has had to be called away, so he's deputized me to thank you. It was a very good overview, and obviously you've been, kept really busy for the last 2 years, despite the COVID pandemic. Has anybody got any questions for Jennifer?
Maybe I can start, Nicole.
Great, thanks, Ewan.
So obviously cough is a very complex symptom, and excuse me for stating the obvious. I just wanted to know, what do you want to achieve? And look, I don't want to be confrontational here.
No.
What are you trying to achieve at the end? What are you trying to actually educate clinicians about? Or once all of your studies are over, what do you want to get out of this, and what would then benefit the patient down the track and the physician?
Yeah, so we would be looking at developing a working instrument to assess cough and its impacts on patients that can be used by the clinician in the outpatient setting. So something that obviously doesn't take up a great deal of the clinician and the patient's time, but gives a good gauge for us about the impact of the symptom and effects of treatment. And then by doing this process formally, also a tool that could be used in clinical trials as new treatments come through for cough.
And how is this instrument going to be different to the other ones at our disposal?
Yeah, so I guess that's why at the beginning we did the review, looking quite carefully at what's already available. And there are differences in some of the more generic cough assessment tools, such as the Leicester Cough Questionnaire or even the Cough and Sputum Assessment Questionnaire. So there are questions within those tools that aren't relevant to ILD patients. For instance, there are items on mental anguish associated with a possible cancer diagnosis that's one example I can think of. There's a big focus on the nature of the cough. And I think it was interesting going into this research. My suspicion clinically had been that most of our participants would talk about a dry cough with diurnal variation. That's what you read about. And that might be what you might be tempted to include in a tool. But really getting the patient perspective means that we're digging down into those other aspects of cough that our patients talk about that others might not. And then, of course, there's the impact of treatments on the patient population.
Even I think, I'll come to you, Kate, but I think, I think as doctors, we like to dish out medications, and if it doesn't work, we get a bit upset and we give something else. And I think we're not very good at addressing symptoms. And I think this will bring to the fore how important symptoms are to our patients. And I think, by doing the questionnaire in the waiting room whilst waiting, you get a sense, how important these symptoms are to your patient. And ultimately, you want to capture that in its essence. And I guess, if there is treatment for cough, you want to have a tool that can measure that change in outcome. So the question is, we don't know. So we don't know whether our tool is better than the existing generic tools. We'll be looking at that as well. We don't know whether our cough, questionnaire can actually capture change over time. So it's all those things. So I think, I think there is need for a specific tool, but whether it outperforms the others, only time will tell. But Jen has a very keen interest in symptomatic management, and this is something that she's quite passionate about. So yeah, so hopefully it'll get somewhere. But it is the nature of research. You're right. So that's our hypothesis. Yeah. There might be a chance it's not any better than the generic tool, but we don't know that. But yeah, it's all all part of doing a PhD in research.
And hopefully you learn a lot about cough along the way.
Yeah, and I think Jen's learned a lot. She's done courses on psychometric properties, some of which I can't even spell. Looking at the different questionnaires, and even designing a Delphi itself. It's been quite challenging in itself. So it's all part of learning. But you're right. So ultimately, we want something that can measure a symptom that's important to our patients that we don't really explore a lot. And ultimately, we want treatment that can measure a meaningful change for our patient. And we know that proms are really important, becoming really more important for clinical trials. I mean, they're never going to be a primary outcome, but I think it's important to have them as important secondary outcomes. And obviously that could impact on quality of life as well. So it's all tied up with quality of life and living a better life. Kate?
Thank you, Nicole. Jen, perhaps you could answer your screen.
Oh, yeah.
I'll see if that's not too hard. You actually, oh, sorry, I've forgotten that I've moved. I moved to my big screen. Nicole has actually half answered my question in the comments she's just making. I wondered whether you were very surprised to find that the patients didn't talk to their clinicians about their cough when it's their most important symptom. And surely, yes, here's an opportunity for the clinicians to make sure it's something that is always discussed, because it just seems a bit mad if this is their main thing they're fussed about, to be just popping down to the chemist and asking them about it. It just did it surprise you? I
think this was, and probably when we do the focus groups, we'll capture some different personalities as well. So this was, I think one thing that was quite homogeneous about this patient population is that they were fairly motivated. So they were quite focused on disease modification and what their lung function was. So that time with the physician seemed to be quite valuable, but they did want the education. But a lot of them talked about the specialist clinical nurse or the physiotherapist or the pharmacist as giving that to them. So that theme emerged later in the session, so in the interviews. So that was quite interesting, and perhaps having a structured session on cough that could be available or might be something that might be useful for those who are interested.
Yeah, that would, I mean, yes, it might be a good sort of a webinar thing to have always available on a, I don't know, LFA or somewhere. Yeah, no, that's interesting. Yeah, thank you.
And I think Jane brings up a very important point. You know, I think physician can't do everything. You know, we can, but we can't. And I think it's a very the fact that the pharmacist can help your patient, the physio can help your patient, the speech path can help your patient. It is a multidisciplinary approach to even symptoms. So I think it's really important to recognize it is a team approach, and there are multiple modalities that perhaps could modify this terrible symptom.
So please don't think I was being critical of.
Oh, no, not at all.
No.
Just if it's going to be the most trying symptom for the patients, it's just fascinating that they didn't choose to bring it up with their clinician.
Yeah. I think when you clinic, we often go, so how's your breathlessness, or let's look at your lung function, or and how's your diarrhea from your nintedanib, and then it's like, and that's it, your time is up. So in an ideal world, we would like to explore every possible symptom. And I think the patients often they're so hung up by that for lung function as well, because, is it worse? Am I ever lost more lung function? So I think it is an important priority, but I mean, I think when we drive the consultation, we often start with, how's your breathlessness? How's your activity? And let's look at lung function. So I think we are as much to blame. And so this is part of, bringing awareness to our, our group, that, it's not just about the lung function and breathlessness and activity, it's also about the cough and the mental health and all those different things. So it's as much helping the patient, but also educating larger population at hand.
And I guess they also saw the cough as inevitable. They just saw it as part of a package of, and I think they all accepted that was how it would be, which I also found quite interesting.
Thank
you. I think that might be part of, I mean, I often say, there is no treatment that can modify your disease to modify your cough. We can help your symptoms. So I think part of it's also, we can be a bit nihilistic but when I see someone, I always ask about reflux, post-nasal drip, asthma, smoking, vocal cord dysfunction, because, you can modify those things. But if it's truly down to just pulmonary fibrosis, we know, there are no, I mean, there is that drug trial that's come out that's proven positive, but it's not available in the PBS. So I think a lot of this is, I think this is important for the patient, but also for us as doctors and this group, to realize that this is a significant part of their disease.
So when the patient's first diagnosed, is there, this is probably something I should know the answer to, but I don't. is there a standard booklet that covers all the basic symptoms and all the basic ways of dealing with it? So I asked this question with my background in cancer, where, you know, there's a special Cancer Council booklet for every type of cancer, and it's really basically got the answers to all the questions, and the patient takes it home, and they're such a valuable resource. Is there something like that for people with ILDs?
In development, Alison.
Yeah, Alison. I think Jen's been involved. Jen and Alison and the TEDS group been involved in really, you know, writing sort of, you know, patient booklets, and I think Jen's been involved in the writing group for cough. Do you want to tell us about that, Jen?
Oh, so we have, well, it's in the works, in the final editing stages, but we have developed a patient information booklet on cough and breathlessness.
Oh, great.
Pulmonary fibrosis. So hopefully that gives them some simple strategies to deal with it.
You know, the Cancer Council books are just such an important tool. You know, between, and you know, I know there's many more people that have cancer than have pulmonary fibrosis, but so you can get those things around, but it just, to have something that's trusted that you have at home is so valuable.
Yeah, Alison, do you want to talk to the resources we have in the LFA for our patients?
Yeah, thanks, Nicole. We do have a growing suite of resources specifically developed for people with pulmonary fibrosis that the CRE team and Lung Foundation partner to produce. The cough and breathlessness one that Jen and Nicole have mentioned is in the final stages of review. So in the next, say, 2 months, that should be published and available on the website, and we'll also, you know, we'll make sure to promote it around this group and the broader CRE network. And there are also like a whole range of other resources that are already available, booklets, fact sheets, recorded webinars that can be watched. And the group is also reviewing external resources produced by other groups around the world, and you know, vetting them and making the ones that are considered appropriate and useful for the Australian population to be added to the website. So we've done quite a bit of work in this space, but perhaps some more to promote what's available.
Yeah, and now that you come to mention that, you know, I'm aware of those things on the LFA website, but it just, yeah. Thank you.
And right. Hi, Nicole, it's Sasha.
Hi, Sasha.
And of course, we would welcome at the Lung Foundation any support or ideas of how better to extend that information and those communications to a wider group. Because, as Kate says, this is a rare lung disease, and there are respiratory physicians all over Australia, but how do you encourage them when they're making this diagnosis to then say to the patient, there are these resources available at the Lung Foundation website? And obviously most of them unfortunately are relying on being PDF rather than an actual physical booklet because of the numbers and those kind of things, and the vast variety of different booklets that are available. So I think that that's perhaps something that we need to think about, how best to ensure that that comes to top of mind when people are diagnosed.
Yeah, I think even being aware there is a Lung Foundation, you know, website where we house all these really important resources. So I think if that's important, like they don't need to know exactly what's there, but you know, if they know there's actually a reliable website that's been vetted, that the patient then potentially can go to it. There's also, you know, obviously there's a patient portal, but also the, you know, professional portal with all the toolkits for the MDMs and, you know, all the stuff as well. So yeah, I think we need to brainstorm about how we're going to promote Miss Sasha, because, you know, half the battle is knowing that's there, you know. But I think, you know, Kate's got a very good point. Cancer, it's emotive, you know, it affects the young people, you know, and there are good cures around cancers by and large, but we're dealing with a disease that's relatively rare. There's not a, you know, funding's not, it's often overlooked in our area because it's not sexy, you know. So a lot of it's, you know, obviously interests, common causes, and also, you know, people are just not as invested in this area as lung cancer is, and a lot of pharma companies don't have the same amount of money to pour into it. there's a lot of pharma companies will support cancer, whatever. But when it comes to interstitial lung disease, it's like, it's only a very small part of the pie, unfortunately.
I suppose another really important thing from the messaging of the books from Cancer Council is that people are able to direct their patients or their family members or whatever to that thing and say, okay, look there, but don't look anywhere else. Don't go off to Dr. Google. You can't trust that, but you can trust what's there at the Lung Foundation. And that was always a really important message. Talking to the cancer patients, don't go listening to people who are, I don't know, tell you to stand on your head and eat pawpaws, because it probably doesn't help. Okay, thank you. That's all for me.
No, but thank you, Sasha. I think, we do have to think, how do we disseminate this, this message and get the wider population to know that this is the really important, which we all worked very hard to develop, and how it should be utilized, basically. Do we have any more pressing questions for Jen or anybody else on this platform? No. Well, Paul's gone AWOL. And so I will close this meeting. And I think the next one, Kate, is do we have a next one? You're on mute, Kate.
I unmuted and pressed it a second time. 17th of June, from Christina Begcup from Monash.
Perfect. Excellent. Well, thank you, everybody. Have a good weekend.
Thank you.
Jen. Well done.
Thanks, everyone. Thanks, Jen.
Jen.
Bye. Congratulations again, Joanna.
Thank you. Thank you so much.